Hello everyone, welcome to session 5 of CAHA's annual Greening the Healthcare Sector Forum. This session's called Stories of Healthcare Resilience in Climate Impacted Communities. We're really glad you're joining us today and I'm delighted to be facilitating the session. My name is Karyn Bosomworth and I am the Manager of Healthy and Climate Resilient Communities Program at the Lord Mayor's Charitable Foundation in Victoria, Australia. But to start, I'd like to acknowledge that many of us are joining today, that many of us who are attending today live, work and play on the lands of the oldest living culture. And I acknowledge this privilege and responsibility with respect, humility and a willingness to listen and learn. Personally, I'm joining you from the unceded lands of the Wurundjeri Woiwurrung peoples and pay my respects to their elders past and present, and acknowledge the continuing connections to culture, community, lands and sea. I'd like to extend that respect to all elders past and present of the lands from which all of you may be joining us, to the young leaders across traditional lands and the changes they are informing, and to any Indigenous peoples who may be joining us today. As we gather to hear stories of healthcare resilience in climate impacted communities, I also want to acknowledge that traditional owners and custodians of country hold knowledge of health and well-being practices that have been practiced for thousands of years, and that Indigenous peoples have much to teach us about ideas of well-being and resilience, particularly as we live through increasing tumultuous times. With that, CAHA would also like to give a shout out to Bupa Australia, who, as a platinum sponsor of this year's Greening the Healthcare Forum, has enabled this virtual event to come to life. So thank you, Bupa. A few housekeeping notes before we get going. At the bottom of your screen, you'll see the following. There's a discussion forum. So we encourage you to utilise that throughout the session with other attendees as a form of discussion. You'll see a Q&A section, so please feel free to use that throughout the session to ask questions for our presenters, and we will come to those at the end of the session. A reminder that the session's being recorded and it will be available later via the platform for about 4 months after the conference. We also encourage you to visit the poster room after this session, and you can access that from the main virtual lobby. Also, CAHA would like to hear your thoughts and reflections on today's session. So they encourage you to please tag them at healthy_climate on X or the Climate and Health Alliance on LinkedIn. So over the next hour and about 40 minutes, we will hear stories of healthcare resilience in climate impacted communities. I'm very much looking forward to this panel as I know the critical importance of on-ground action. And let's just say I've been in the climate change adaptation field long enough that I attended COP15 as an academic when my hair was brown. So let us begin. It is my pleasure to introduce our first speaker, Vicktoria Blake. Vicktoria is the Principal Advisor, Climate Risk and Resilience for Te Whatu Ora Health New Zealand. She is also one of the co-chairs of Sustainable Healthcare Aotearoa. I messed it up. I'm sorry, Vicktoria. Aotearoa, and on the executive board of Ora Tiao, New Zealand Climate and Health Council. She also tried graciously to help me with my pronunciations, but I'm not sure I did so well. So if I could hand to you, Vicktoria, that would be wonderful. Thank you.
Oh, sorry, you can hear me. You can't hear me. Okay, right, sorry. Kia ora whānau. Kia ora tātou. I whānau mai ahau hira taonga I te mātou a Maui. No Antigua me Peretini nui oki tūpona. No rongamai wāhi ne tōku tama. Kei tauranga moana ahau I noho ana. Ko Vicktoria Blake tōku ingoa. Kei te whatu ora ahau I mahi ana. Kia ora anō. My name is Vicktoria Blake and I am based in Tauranga Moana in the sunny Bay of Plenty in the North Island of Aotearoa, New Zealand. I have the privilege, as noted, of holding the role of Principal Advisor Climate Risk and Resilience at Te Whatu Ora Health New Zealand. A bit of a disclaimer, I'm still recovering from being unwell, so I apologise in advance if I have a coughing fit and I have water on hand, so I should be okay. For context, Health New Zealand is responsible for the delivery of publicly funded health services across Aotearoa New Zealand. Health New Zealand manages all health services, including hospital and specialist services and primary and community care. Health New Zealand is New Zealand's largest employer with a workforce of around 80,000, not including contractors. Before I begin, I would like to start with this whakatauki or proverb. Ka ora te taiao, ka ora te tangata. If the environment is well, so too are the people. This really acknowledges the fact that we are a part of nature and not apart from it. This talk will discuss climate change scenarios that have been created for the health sector in Aotearoa, New Zealand, some of the findings and some of the successes. Before we start, it's important to note the context of this discussion in an Aotearoa New Zealand context. Various legislation, directions, government strategy and agreements guide the work that Health New Zealand is undertaking in relation to the impacts of climate change on our ability to deliver publicly funded health services. Understanding these impacts, the impacts that climate change may have on population health and subsequently our ability to deliver health services is critical. New Zealand is also a proud member of the World Health Organization's Alliance for Transformative Action on Climate Change and Health, which we understand Australia is now also a member. For that reason, Health New Zealand, alongside many other organisations, over 30 public and private entities in total, with those who financially contributed to the project shown here, worked collaboratively to create climate change scenarios for the New Zealand health sector, asking the question, how could climate change plausibly affect population health and the health and disability sector over the short, medium and long term? Also pictured here are the members of the leadership group, which represented senior leaders from both public and private health providers. A quick shout out here to my colleague Arvine Horsfield. It was our joint leadership and strong commitment to cross-sector relationships and systems change that really ensured such a robust project. And to the fantastic team at Tonkin and Taylor, particularly Benjamin Sims, James Hughes and Murray McCarthy, who facilitated the project. Climate scenario planning is a tool that can help organisations navigate complex and uncertain futures. The process involves developing scenarios which are plausible hypothetical narratives about what the future might look like that can help with strategic planning. Within the climate change context, scenarios are often used to test strategies, identify climate-related risks and opportunities, and then assist with transition planning. The purpose of scenario analysis under New Zealand's climate standards is to help entities explore the climate-related risks and opportunities they may face, and therefore better understand the resilience of their business model and strategy. Under New Zealand climate standards, the New Zealand External Reporting Board defines a climate scenario as a plausible, challenging description of how the future may develop based on a coherent and internally consistent set of assumptions about key driving forces and relationships covering both physical and transition risks in an integrated manner. The health sector scenarios provided alternative views of the future, grounded in key drivers of change and uncertainties. They considered hypothetical, plausible stories about conditions and events which may occur. However, they're not presented as predictions about what will occur. Whilst these scenarios have been developed to aid decision-making, the data contained within them is from various sources and should not be relied upon as predictive or probabilistic when making decisions. The scenarios provide a way for organisations in the health sector to consider and challenge their strategies and future plans. These organisations include climate reporting entities who are required to undertake scenario analysis in line with External Reporting Board reporting standards. Currently in New Zealand, government agencies are not mandated to report against these standards. However, Health New Zealand is using this framework to guide the work program in this space. Under these standards, the XRB requires development of, at minimum, 3 climate change scenarios. A leadership group, technical working group, and Te Ao Māori Rōpū, each consisting of health sector experts, was established to support and oversee this work and ensure that 3 sector-specific scenarios presented aligned with New Zealand standards. The scenarios were agreed as followed. Scenario 1, a hot house world, a high warming scenario above 3 degrees. Scenario 2, a delayed and disorderly transition. This is our additional scenario, which is around 2 degrees. And scenario 3, an ambitious and orderly transition, which is our Paris Agreement aligned transition scenario. This slide illustrates some points of global context under each of these scenarios, with the tiles illustrating the impacts on Aotearoa, New Zealand. Sectors that have completed scenario creation in Aotearoa include energy, transport, and property and construction, which are all relevant to the delivery of health services. The health sector scenarios were specifically designed to align with the property and construction sector scenarios due to the extent of infrastructure owned or managed by the sector. This slide illustrates the key focus areas for the climate scenarios. Government funding, while potentially a contentious topic to comment on as a government agency, was described as significantly decreasing in relation to health funding, particularly under the disorderly and hothouse scenarios, as government funding would likely be diverted to dealing with climate response, including responding to extreme weather events such as those faced across New Zealand in early 2023. This commentary is plausible, with the 2023 Cyclone Gabriel estimated to have cost 14.5 billion New Zealand dollars. Ongoing and more frequent events will have a considerable impact on government coffers. Also to note is the overarching comment that climate change will exacerbate stresses that the health sector is already facing, such as health equity and access. However, as noted in the table bottom left, global commitment to significant climate action to keep temperatures below 1.5 degrees could see significant improvements in human health and well-being, particularly relating to air quality and diet. We know that climate change will have a significant impact on the health system and its ability to deliver services, and what services will be required as temperatures rise and other impacts of climate change are felt and impact the population health profile. This slide identifies key areas of impact that are likely relevant for broader than just health. In fact, we recommend all sectors read the health scenarios to begin to understand the impact climate change may have on their people. The creation of the climate scenarios is a first step as Health New Zealand and our Ministry of Health work together to create plans to ensure a resilient, publicly funded health service. A Health National Adaptation Plan was released in October 2024 by the Ministry of Health, with Health New Zealand working to understand the implications of both this and the recently published scenarios as it works through creating its own organisational risk and resilience plan, as directed in our National Adaptation Plan administered by our Ministry for the Environment. Some key issues that must be considered include impacts on workforce, funding envelopes, operations, including building performance under temperature rises and weather-related impacts, and supply chain impacts that could include both access to supplies alongside significant cost increases, whether caused by physical risks or transition risks as international policies shift toward a low-emissions future. We experienced some significant wins throughout this project, many of which are listed here, but the most significant of these were the strong relationships that were formed and are continuing to support work across the program, ensuring that the various parts of the system, both within and outside of health, particularly from a Crown entity perspective, are working collectively in solutions to ensure reasonable resource allocation, reduction in duplication, and significantly robust outcomes. These relationships have really ensured the breaking down of silos and seen a lot more partnership work across the system in discussions relating to climate change and sustainability. This has been a big year for the climate and health conversation in Aotearoa, New Zealand, with the release of the climate scenarios in May, the Health National Adaptation Plan in October, alongside a research project commissioned by the Ministry of Health discussing extreme weather event impacts on health and well-being in Tairāwhiti and the Hawke's Bay here in Aotearoa, relating to Cyclone Gabriel and subsequent weather events in the regions. The reports, research and plans published this year provide a sound foundation for progress in this space moving forward. However, we still have some work to do and could be partnering across Australia and New Zealand to find some of the answers. We need to develop a deeper understanding of the impacts on human health and well-being stemming from climate change and its direct, indirect and transition related risks, particularly in our geographical areas. We need to understand financial and health costs implications stemming from the impacts of climate change and the benefits that climate mitigation action can bring. We need to start to build some metrics and really help to inform policy, not just within the health system, but across all government policy and the impacts that that will have and the costs that will bring, not at the time of purchase, but ongoing. Health New Zealand has a significant 3-year work program in place, with this being the end of the first year. The next steps for us include a climate adaptation framework that will help us to understand priorities, risk tolerance, and adaptation approaches, with our first climate response plan due in December 2026. Let's continue to work together to find solutions to the wicked challenges that climate change will require us to face. Ngā mihi nui kia koutou. Thank you so much for your time today. Please do not hesitate to reach out if you want to discuss this work in any further detail. Kia ora whānau.
Thank you, Vicktoria. Wow, such great collaborative cross-sector efforts, forward and systems thinking. And I love the use of scenarios. Now I'll hand over to our second speaker, Elise. Elise is a research fellow in climate change and health at the University of Melbourne, where she coordinates the Climate Collaborative Action for Transformative Change in Health and Healthcare Lab, or CATCH for short. Elise has a background in public health and international development, with several years' experience managing global research, policy advocacy, and health systems strengthening projects in diverse contexts. Over to you, Elise.
Great. And thank you, Karyn, for spelling out the full CATCH Lab acronym to save me doing that. It is a long acronym, but it captures some of the key points that our unit is all about. So funding for this project that I'm presenting on advancing climate resilient and low carbon health systems interventions from the Western Pacific was provided through the World Health Organization's Asia Pacific Centre for the Environment, and some of the co-authors from that team alongside other co-authors are noted on screen. And I'd also really like to thank and acknowledge the Climate and Health Alliance and the Global Green and Healthy Hospitals Network, who facilitated access to their wonderful repository of case studies, which provided critical implementation evidence for this research. This research collaboration was rooted in the urgent need to address both the impacts of climate change on health systems, as highlighted by this WHO figure on screen, but also health system contributions to the climate crisis, primarily through healthcare waste and greenhouse gas emissions. And we know that these impacts and vulnerabilities are becoming more and more pronounced, both globally and in our region. This was made ever clearer by two recent reports. The 2024 Lancet Countdown on Health and Climate Change, highlighted on the left here, found that 10 out of 15 indicators that monitor climate-related health hazards and impacts have worsened in the past year. And Australia's State of the Climate report also showed undeniably parallel trends of warming sea and land temperatures alongside ever-increasing concentrations of atmospheric greenhouse gas emissions in the past century. So I know I'm preaching to the converted here, but given the threat that climate change poses to both health and health systems and healthcare's contribution, both mitigation and adaptation efforts are needed to reduce the problem at the source and adapt to the inevitable impacts that are already locked in. The WHO's operational framework for building climate resilient and low carbon health systems seeks to address these dual needs by synergistically integrating climate resilience building and adaptation with emissions reductions efforts. The operational framework was first introduced in 2015 and updated in 2023. So we conducted a rapid review in partnership with WHO to identify case studies of low carbon and climate resilient health systems and health facilities interventions in 6 Western Pacific countries: Australia, Fiji, Laos, Mongolia, South Korea, and Vietnam. These 6 countries were selected for both practical and conceptual reasons. So theoretically, they represent the region's diverse climate vulnerabilities, ranging from extreme weather exposures to rising sea levels, particularly for our Pacific Island colleagues. And practically, this selection enables an analysis of climate resilient and low carbon health system interventions within a range of governance and policy settings, including greenhouse gas emission commitments, and we hope enhancing the applicability of the findings across different contexts. So we undertook a rapid review that was with a protocol co-designed with the WHO partners, and we included a broad mix of academic and grey literature databases. We identified 605 sources overall, and I won't go through each layer of this framework, but essentially we identified 41 sources that met our criteria and 43 case studies out of those sources, because some documents or sources describe more than one case study or country. And our analysis was guided by the WHO operational framework, including the 10 components of climate resilience healthcare systems, which are outlined on the left, and the 4 domains of low carbon and environmentally sustainable healthcare facilities on the right. So in terms of an overview of the 43 included case studies, the majority were identified from grey literature. So it was great that we included quite a large selection of grey literature databases. And most had been published in recent years, with a peak in 2022. More than half of the case studies were reported from Australia, followed by Vietnam, Fiji and Laos, with a smaller selection from South Korea and Mongolia. The majority focused on, of those case studies, the majority focused on low carbon or environmentally sustainable decarbonisation pathways, with a smaller percentage focused primarily on climate resilience. However, we did identify around 10 or 23% that were synergistic, so that targeted both environmental sustainability, low carbon mitigation efforts alongside climate resilience and adaptation efforts. And I've got 2 examples of those later on in the presentation. In the Venn diagram, the interventions in the green circle on the right included activities whose primary purpose was to build climate resilience. We found of those that low carbon infrastructure, technology and supply chain interventions were the most frequently reported, followed by leadership and governance, health workforce, integrated risk and emissions tracking, and environmental determinants of health. Of those focused primarily on environmental sustainability and decarbonisation, majority of those were initiated through bottom-up or health facility level processes rather than top-down health systems initiatives. And while greenhouse gas emissions data was not consistently reported, the majority referenced indirect Scope 3 emissions, primarily related to waste and supply chains. We also looked at other aspects, including co-benefits, barriers and enablers. So we described co-benefits as the positive effects resulting from actions targeting one objective that extend to other areas. We found a large proportion or majority of case studies reported some kind of co-benefit, ranging from financial savings, social and community inclusion, health benefits and improvements in quality, safety and efficiency. More than half of the case studies also identified barriers such as limited capacity, low staff engagement and lack of technical support, restrictive guidelines such as clinical restrictions, competing priorities and lack of resources, including financial resources, human resources and time for implementation. Some case studies also identified the perceived higher upfront costs and COVID-19 disruptions as barriers. In terms of enablers, those identified included strong leadership, governance and stakeholder coordination, which I think Vicktoria's previous presentation also highlighted. The presence of dedicated resources such as sustainability champions or coordination personnel, robust relationships and partnerships, both within healthcare facilities, but also with external partners, as well as education, communication and engagement strategies. And we also found that having mandatory reporting frameworks around climate resilience and sustainability was identified as an enabler. So just delving a little bit deeper into the data, I thought I'd share 2 of those synergistic examples. So between 2020 and 2021, the government of Fiji, with the support of the WHO, developed guidelines for climate resilient and environmentally sustainable healthcare facilities. And these guidelines are actually available online if you just Google Google the title. The vulnerability assessments of healthcare facilities across Fiji's central and western divisions highlighted significant climate risks, with over 70% facing flooding and more than 90% exposed to extreme weather and ageing infrastructure. So following those assessments, the guidelines were used to identify priority interventions for retrofitting, including safe water solutions, conducting energy audits to improve efficiency, and implementing non-burning waste management systems. So these initiatives aim to both build resilience in the face of compounding and increasing climate risks, but also to reduce the environmental impacts of healthcare facilities. Similarly, a case study from the Nepean Blue Mountains Local Health District in Australia highlighted the importance of strong policies, governance, and low-carbon infrastructure investments to boost resilience. A climate resilience healthcare focal point was established to prepare for climate-related health impacts, informed by historical events such as the 2019 to 2020 bushfires and flooding in 2021. Efforts were complemented by infrastructure upgrades such as energy efficiency enhancements and transitioning to a hybrid vehicle fleet. And the diagram on screens highlights the governance system across both policies and guidelines or documents, having a leadership framework as well as having access to resources to promote education and accountability. Just checking my time. So in terms of our findings, as I mentioned, there was a geographic bias towards Australia, suggesting there may be a gap in published evidence from low and middle income settings that were included in the review, as anecdotally there are several efforts underway in some of those countries. The majority of case studies also focused on environmental sustainability and decarbonisation, as well as Scope 3 emission sources. Fewer case studies were focused on climate resilience, and of those, it was more commonly featured in low and middle income countries. So we hope that efforts to integrate climate resilience and environmental sustainability, so those synergistic efforts, may become more prominent over time. We found also that the efforts to reduce greenhouse gas emissions and waste were primarily initiated at a health facility level, so through these bottom-up interventions, suggesting a grassroots approach to environmental sustainability is vital for driving change within the sector. We also found that the cost of interventions was very rarely reported beyond projected savings over time. So this makes it difficult to identify best buys or the ideal package of interventions that deliver the greatest benefits in terms of climate resilience and carbon reduction. And we also found that community engagement was a key additional driver and perhaps a missing element of that WHO operational framework, particularly in areas where health systems are very strongly embedded in communities. Just briefly, there were several limitations of this research. So we focused on implemented interventions and did not include plans or commitments or strategies, which may have limited results. We also used the WHO operational framework and its definitions of climate resilient health systems, which, despite being first published in 2015, are relatively new, which means that it may not be widely reflected in published literature. And of course, we had a very small sample of countries because of those conceptual and theoretical parameters, which again means that we may have missed relevant interventions from the region. In terms of next steps, a full manuscript is currently under review and we're hoping it will be published imminently, and we would be happy to share links when available. And I've also just left some links on the screen about our Climate Catch Lab. Our website often features new research and initiatives from our team. Thank you. Hopefully I'm right on 12:30.
You're bang on 12:30. That's super impressive. So thank you, Elise. It's really important to have this kind of research and analysis so we know where we are and where we need to go and where we could go. So again, it remains my pleasure to introduce the next two speakers, and they're from Loddon Mallee Public Health Unit and Bendigo Health, Kate and Carolyn. I feel like I've met Kate so many times online. One day we will meet in person. Kate has worked in sustainability, environment and health sectors for more than 20 years. including in research, private consulting, state government, not-for-profit, and now with Loddon Mallee Public Health Unit. With a PhD in governance and sustainability, Kate brings a systems thinking approach to regional climate and health leadership and capacity building in the Loddon Mallee. And Carolyn lives on Jarrah country in Castlemaine, beautiful, with her partner and 3 sons. She's a climate change and health project officer with the Loddon Mallee Primary Health Unit and is passionate about social and environmental justice. It says here that she loves playing guitar badly, hiking and a whiskey with friends. I'm hoping they're not in combination. But anyway, I will hand over to you, Kate and Carolyn. Thank you.
Thanks so much, Karen. Good afternoon, everyone. So, as mentioned, Caroline, and I are presenting today on a regional approach, the Loddon Mallee Climate Change and Health Framework. We're from the Loddon Mallee Public Health Unit, and we're one of 9 public health units in Vicktoria, Australia. We acknowledge the First Peoples of Australia, who are the traditional custodians of the land and water where we live, work and play. We celebrate that this is the oldest living and continuous culture in the world. We have deep reverence, compassion and humility for First Nations people and culture and recognise that sovereignty was never ceded. Today I'm on Dja country and pay respects to the people of this place and the knowledge they hold from thousands of years of caring for country. Their knowledge and traditions are what we need to aspire to learn from to heal ourselves and the world around us. The Loddon Mallee Public Health Unit works to keep our regional community healthy, safe and well. We do this through a place-based model. My work is across the whole region and my colleague Kaz works in one of our 3 sub-regions. We use local knowledge, community-based relationships and direct engagement to tailor and deliver public health initiatives and to respond to incidents and issues. Whilst we're primarily focused on prevention and population health and protection, we also intersect with environmental health and emergency management. There are 30 healthcare services in our region. Our key partners are with primary, acute and community health services, state government agencies, local governments and local communities to promote health and wellbeing and tackle inequalities in health. We are a climate impacted region with significant recent floods in the north and bushfires a constant threat. So we're increasingly vulnerable to the increasing public health risks of these bushfires and floods and other extreme weather. And we have many small rural communities that have very limited access to services and infrastructure. Compared to the state average, our population is more socioeconomically deprived with a worse health risk profile and less access to health services. There's also a relatively large Aboriginal population in our region, and we also have significant seasonal movements of agricultural workers and tourists throughout the year. The Climate Change and Health Framework, which I'm addressing today, launched last year in June 2023. It came about as a place-informed approach to address a gap that had been identified across those working at the intersection between community health, healthcare services, social justice, First Nations, sustainability and inclusion areas. We had really significant internal champions for this work, along with a shared view with stakeholders of the urgent need to address the escalating impacts of climate change. In developing the framework, we leveraged existing organisational relationships and networks. And this is what really helped the framework to succeed. There was a shared understanding that existing public health approaches were not enough in our region. The inequitable impact of climate change is amplifying existing public health issues and exacerbating inherent uncertainty, health inequalities and disadvantage. So we had strong existing relationships to cross-sector stakeholders who recognise a significant opportunity here to prioritise climate change adaptation across health and community services through evaluation of climate change risk. And on the slide here, you can see the steering committee of the framework, which was quite representative of our major stakeholders. So mitigation and adaptation are at the centre of our framework, as you would expect. And as many of you know, it's adaptation where more knowledge and understanding and social learning is really needed. And that's where we're working actively to build capacity. The objective was to develop a Loddon Mallee climate change and health framework in collaboration with local cross-sector stakeholders to guide the implementation of climate change mitigation and adaptation across the region. This has really been a first in our region, and as far as we know for public health in Victoria, the first time climate change and health had been brought together in a framework to guide cross-sector action at a regional scale. We take a strengths-based approach, noting that there are many climate actions already occurring in our communities and that are promoting mitigation and adaptation. As a public health unit, we're fortunate to work to both community audiences and to healthcare professional audiences and many in between. We attend festivals and speak with the community, develop resources, work with local government, and also support hospital boards to address improvements in sustainability, adaptation and mitigation practices. So we're working with those healthcare services that are ready and those community health organisations and councils that see the value in a collaborative approach. What does our framework recommend? So that structures are in place to enable collective cross-sector action to build climate change resilience in our region, to raise awareness of how climate change impacts people's health and well-being and the co-benefits of climate change action and health outcomes. It recommends to build climate change mitigation and adaptation capacity within health services, and to explore cool spaces models for implementation across the Loddon Mallee region, whilst also embedding Aboriginal and Torres Strait Islander self-determination in climate change adaptation. So how are we doing this? We are advocating for policy improvements at state and federal scales. We're convening our cross-sector stakeholder groups in discussions to share understanding, gather support, and create communication tools to unpack the links between climate and health. We're supporting healthcare services to focus on, prioritise and improve sustainability, mitigation and adaptation measures. We're promoting the links to social justice, social determinants of health and climate change, and working with stakeholders specialised in these areas. We're working with community services and local government to amplify their concerns and impact and assist in solutions. For example, we're spreading awareness of cool spaces, which are very much needed in the summer, and how to establish them. We're supporting novel research into regional climate change and health issues. And we're on a learning journey of how First Nations' understanding of health and wellbeing transcends the separate silos that we have created that disconnect us from ourselves, our communities and our environments. So here's some examples of some resources that we have developed recently, including a poster, our vision for a climate change resilient Loddon Mallee, which describes the positive but sometimes under the radar activities that are going on in our communities to support climate resilience, and also translated resources showcasing the links between climate and health. And here is us, Kaz and I, at the Bendigo Sustainability Festival earlier this year, chatting with the community. So what are we doing specifically with healthcare services to implement the framework? So we're providing advice on guidance documents for climate action. We're engaging with exec leadership teams to showcase what can be done and where to start. We're supporting in practical ways through revising sustainability policies and action plans, and we're exploring the development of a staff climate and health training module. And we're illustrating the benefits of Global Green and Healthy Hospitals Initiative membership, and we currently have 7 Loddon Mallee Health Services as members and 1 in application. I'll hand over to Kaz now. Thank you.
Thanks, Kate. Hello, everyone. So I'm Kaz Neilson, and I live and work on dispossessed Jarrah country. So it's a real privilege to speak to you today and share a little bit about the work we're doing. And thanks, Kate, for a wonderful introduction. As you can tell, I'm from Scotland, so I don't think there are any Scottish subtitles, Karyn, in this session, but we'll see. Maybe people will understand a little bit. So yes, this is a slide. So I'm going to talk a little bit about the sort of more place-based approach with our health services in the Loddon sub-region. So here we have one of our local GPs, Louisa Hope, and this was taken, it was a bit of a media release after we had some wonderful Climate and Health Alliance training for 3 practices, all the practices in our Mount Alexander Shire. It was an incredible training. They were already doing magnificent work in their sustainable healthcare, but this really built on that, affirmed what they were doing, also affirmed, I think, and I'll talk a little bit about this later too, that they are part of a community, not just service providers in their mitigation and adaptation, and built on the sort of cross-practice collaboration. Thanks, Kate. So health services, they are essential actors in climate change action. We know that. In the Loddon PPH sub-region, I work with 5 primary health services and 4 community health services. They're very different. They have common needs, but quite working with diverse communities. Some communities more on the climate change mitigation and adaptation journey than others. They're quite different in size, and working with health services, they range from, say, staff of about 80 to a bigger hospital of thousands of staff members. They are trusted anchor organisations in their community. I think rurally and regionally, there's not so much the separation between service provider and community. It's seen more as an intact ecosystem in terms of adaptation, mitigation, and community development. Importantly, as I've said, they're major employers and emitters of carbon emissions, but working on that and acting on that. And as we've seen, and as Kate has exemplified and illustrated, the climate change action in these health services really requires a whole organisational approach supported by strong leadership and governance. So we're really talking to our health services about the policies that are guiding this action, that it's referenced in strategic plans. They have robust action plans, robust monitoring and evaluation, KPIs embedded in lots of organisational documents, accreditation standards, risk assessments, a robust communications strategy. They're the sort of things we're really trying to build within the health services. Thanks, Kate. So as I've said, they're essential actors. We're starting with mitigation. We find, understandably, our health services are really, that's where they're sort of starting point in the mitigation, and they're following the Global Green Healthy Hospitals agenda in that. And I think some health services, it's where the motivation, where the inspiration, where is the knowledge, where's the capacity, and they start there. But as I'm saying, we're really trying to encourage them to have overviewing governance and strategic direction to hold that passion, that commitment, and do it justice. So I won't go into too much detail here, but you can see, I think you're all aware of the different mitigation actions that we're supporting our health services in embedding in their organisational practice. Thanks, Kate. And Kate touched on this too. There's quite a focus on mitigation. We're really trying to encourage dialogue and action in adaptation, and we're referencing the Victorian Government DHHS Climate Change Adaptation Action Plan. So certainly Kate referenced the importance of embedding Aboriginal and Torres Strait Islander people's self-determination. And we were fortunate the Loddon Mallee Health Network really provided opportunities through a wonderful Yorta woman, Jean McMahon, to build our cultural humility and transformational accountability in this. So moving from cultural safety to anti-racism, really unlearn systems and learn new systems. So I was very privileged to be on that journey. Health and social equity. We recognize climate change really amplifies systemic disadvantage. So building on that health and social equity as it is in organizational practice, as well as in our intact community. And the connection, building those connections with our community, the service provider community interactions and engagement. And I'm going to talk a little bit more about this, but this cross-sector collaboration and with community we feel is absolutely vital in adaptation and mitigation. Thanks, Kate. These are some more actions that are referenced in the Victorian State Government Climate Change Adaptation Action Plan, so I won't talk too much to them. But certainly in our risk assessment dialogue with our health services, we look at improving mental health services, the surge workforce that's required, the staff well-being, and all of the sort of risk assessment that's really, really important. Thanks, Kate. And so I just wanted to just touch a little bit on some of the collaboration that we've been sort of encouraging and facilitating across these 5 primary health services and 4 community health services. As Helen Keller says, alone we do so little, together we can do so much. So we've sort of facilitating a bit of a sort of communities of practice. And in that communities of practice, we've been looking at sharing information and expertise. So for example, one of our bigger health services is doing remarkably, I think, in waste management. It's got 31 waste streams that it's actually diverting from landfill. I think their recycling percentage is up at 40%. So they've kindly come and they're doing audits with some of the smaller health services, guiding them in what waste streams they feel they should focus on. So there's a tremendous reciprocity in this communities of practice, sharing information, sharing communications materials. We're developing collective advocacy in action, and that's including really advocating for equity across the region. We really feel there's inequity as you go further from Melbourne in all its manifestations. I've touched on being anchor organisations in the community and how we can really build on that, build on them being trusted voices of key messages around adaptation and mitigation, as well as leading by example. And they're sharing risk assessment policy and different tracking templates. So tremendous sharing of expertise. If you just go back, there's just one bit. Yeah, sorry, Kate. And the picture here is we've also brought the health services into a bit of cross-sector collaboration. So with neighbourhood houses, local governments and libraries. For this summer, we're actually leading a couple of forums on summer heat. So the health services are part of that really important cross-sector collaboration on that. Thanks. And a bit of a cartoon. What if it's a big hoax and we create a better world for nothing? So arguably, you know, if we're creating a better world that, you know, is addressing social and health inequity, we're addressing the pathology that's caused by social inequity, we might not need so many health services. Hopefully they'll be doing other valuable work. Thank you.
Well done.
Oh.
Wow, thank you. There is a bit of feedback for me. No, there we go. Thank you both. I think that's another great example of the importance of collaboration, working across issues, really systems work. The use of a strengths-based approach, focus on determinants of health as the foundations of resilience, building cultural humility, and health organisations as anchor institutions. And again, it shows how emissions reduction and sustainability are really good entrees into thinking more broadly about resilience. So now to our fourth presenter, Esala. Esala is Manager of Pacific Health at Pegasus Health in Christchurch, Aotearoa. Esala is also a PhD candidate at the University of Canterbury and recently contributed to the Climate Change and Health chapter of the Pacific Ocean and Climate Crisis Assessment book. This book is the largest study of climate change adaptation in the Pacific region, and I believe was recently launched at COP29. So over to you, Esala. Thank you.
Kia ora ni Sambula Vinaka, na Evango Esala Vakamacawai, Angoni ni Viti, Mengaloa Kandavu. My name is Esala Vakamacawai. I'm from the province of Kandavu, island of Ngaloa, also where I did the case study. And this was a contribution to Chapter 11 of the Pacific Ocean and Climate Crisis Assessment project that was funded by Ministry of Foreign Affairs and Trade and published at COP29 last week by the distinguished Professor Stephen Ratuva. And in this, we contributed to Chapter 11 of this book that looked at climate crisis and its impact on health. In the islands, we don't see climate change because we are going through climate crisis. Briefly on Ngaloa Island, it has an average population of about 100 people. In Fiji, population is just less than 1,929,000. 830 communities are vulnerable. 42 communities need urgent relocation secondary to the impact of climate crisis, especially around the coastal areas. 6 villages have been relocated already, and one of them is Dravuni, also in the province of Kandavu. And what's happening in the islands is there's a potential for this to impact larger countries like Brisbane and Australia, given that it's only 2,550 kilometers to Auckland and 2,713 kilometers to Brisbane, and vice versa. Briefly on the history of Ngaloa Island, it has a significant history in Fiji. In 1792, first documented by William Bligh when he came to the islands. 1827 by Dumont d'Urville, who also came up with Melanesia, because I'm black, I'm Melanesian, Polynesian for bigger islands, and Micronesia for smaller islands. 1879 by when the Leonidas brought indentured laborers from India to Fiji. There were 5 crew members who were indigenous Fijians, and they boarded they were all from Ngaloa Island in Kandavu. And this is a drawing of Ngaloa Wharf or Nasalata Wharf in 1887 by J.J. Wild. This is the same place taken. This is a photo I took in June 2023 of the same wharf, looking at the impact of climate crisis. Climate crisis on health can be divided into primary, secondary, and tertiary impacts. And given that 70% of the world's surface is covered by seawater, 90% of global warming is secondary. 90% of global warming happens in the ocean. And because of this, secondary to the high amount of carbon in the atmosphere, hence reducing pH and increasing acidity. With increased acidity that ends up in the ocean, can lead to coral bleaching, weakening the structure or skeleton of coral, leading to coral death. And because of this, fishes, it affects marine life, and islands like Ngaloa and coastal areas who heavily depend on fish for food security are impacted, and their health are impacted as well because of rising acidity in the ocean. Sea level rise, as I mentioned already, 6 villages have already been relocated because of the primary impact of climate crisis on health and the people. Tropical storms are getting severe. In 2016, I was still practicing in Fiji, and we were part of the emergency team that went to Levuka in Lomaiviti. And some of these villages, their stories of the Category 5 cyclone that was the first to hit the Pacific Islands. It sounded like jet engines when it comes, and it just picked up houses, smashes against the neighboring houses. The village that we went to, there was no house at all, but people sat under a tarpaulin. They accepted welcomed us to the community, and at the end of the medical checks, we drank kava and they were singing. So this is a reflection of resilience in a community where there's collectivism. Drought is a big impact as well on Ngaloa Island. With drought, those that can afford sprinklers can have fresh vegetables and cover as well. Cover is important in cash crops because people still need to buy uniforms for their students, school books, send their students to school, get fuel to get more fish from the reef. And also with climate change impacting corals, this affects cash availability of cash on Ngaloa Island. And what happens next is dependence on processed food, rice, flour. These are food that can be available, have longer shelf life, but on the other side of it, it prevents people from engaging in physical activity, uprooting root crops, cutting firewood, hunting, and they become sedentary, secondary to the availability and easy access to processed food. So increasing obesity. Obesity is one of the modifiable risk factors of non-communicable diseases, in addition to unhealthy diet and low physical activity. And when we talk about unhealthy diet, dependence on processed food, secondary to bleaching, this impacts health indirectly on Ngaloa Island. Obesity is, out of all the risk factors for type 2 diabetes and non-communicable type 2 diabetes, obesity is the most significant risk factor, increasing diabetes risk by 52% when compared to other risk factors. Low functional physical activity. When you talk to someone in the village and you talk about exercise and physical activity, in their mind, that is running and going to the gym. But if you tell them that that is not the only form of physical activity, there's also cutting firewood, uprooting cassava, fishing and swimming. These are other forms of exercise and physical activity. And with change in rising temperatures and extreme heat and drought, it impacts the ability to engage in this functional physical activity. For example, with the drought, people go early in the morning and they go late in the afternoon. No one stays in the farm in the daytime because of the extreme heat. So they shelter at home and go early in the morning, late in the afternoon. Also, with low amount of, or with dying coral reefs, I saw young men drinking cover throughout the night and then going out spearfishing early in the morning, 2 to 3 a.m. in the morning, because the water are cooler and bigger fish will come to coastal areas. I've already mentioned that obesity is the most significant risk factor of type 2 diabetes. And when I was collecting data on type 2 diabetes risk on Ngalo Island, even though it's remote, 100 kilometers south of the capital city, Suva, 79% of the population are overweight and obese. And even after describing that exercise and physical activity is not just going to the gym and running, it's also functional activities, 68% say that they are not physically active enough. And according to Siti Venigora, the man that you can see, the old man that you can see on the photo, he believes that climate change has impacted the way of living in Ngalo. When using the American Diabetes Risk Assessment to look at diabetes risk on Ngalo Island, 94% have a high risk of type 2 diabetes, similar to indigenous Fijians living in New Zealand. And however, comparing this to a village in the interior of the main island, the risk of type 2 diabetes is 50%. Other impacts of climate crisis on Ngalo Island, acute gastroenteritis and diarrhea, especially in the younger population, because now with climate change and climate crisis, our water source is affected. So we have to pipe water from Wailewu village, a distance of more than 2 kilometers. So this created a big socioeconomic impact on the villages, because they had to fundraise and gather money to buy pipes and lead sinkers, allowing water to be used on the island. And even the use of lead is a threat to marine life. And every time there's flooding, it can cause acute gastroenteritis or diarrhea in the young ones living in Ngalo. With this, this used to be the water source, but now it's contaminated with seawater. It's now contaminated with seawater, and with this, it becomes a breeding ground for mosquitoes, hence increasing the risk of dengue fever. Poor sanitation also leading to typhoid. When I was there in June last year, there was a case of leptospirosis, and with this kind of poor sanitation and lack of access to water, it creates a favorable environment for the spread of leptospirosis. Tertiary impact of climate change on health. It impacts class. Everyone has the right to be educated, but during King's Tide, or when we have a full moon, the high tide can go into the classrooms if it happens in the daytime, impacting and affecting classes. Also, with the ocean going into the school ground, it becomes a niche for crustaceans who are now digging within the school compound, and that creates a health and safety problem by using the school. If this continues, the young children that you see on the photo will be forced to attend boarding school at Funisia or in the main island in Suva. These are 4, 5, 6-year-old children, and if they are taken across to boarding school at this age, it can lead to intergenerational trauma. And I think of an article that was published in Canada, the First Nation, of how through colonialism the young ones were forced to boarding school, and this created stress and intergenerational trauma later on in life. Other tertiary impacts is coastal erosion. These were burial sites for my ancestors. And if you can see the level of coastal erosion, it's gone past the coconut trees now. Now we're already talking about relocating these graves to higher ground. And to do this, it costs a lot of money. And also the traditional protocols need to be followed. If these are disrespected, not respected, then there will be ancestral mana, and the Vanua will put a curse on the people. And we believe that the Vanua culture also have a significant impact on health, not just physical lack of physical activity and modifiable risk factors. Learnings from this case study: resilient community and health system needs to be upgraded. We need to learn from the past. Ancestral knowledge, cultural component is also important in planning, adaptation, and strategies and preparation. For example, looking at this thatched mbure, when COVID-19 struck, those that lived in thatched houses went back to normal, to their normal way of life 2 or 3 months afterwards. But those that lived in concrete houses and corrugated iron houses, some of them are still living in tents today. Climate crisis is a factor that can contribute to the risk of type 2 diabetes. Health facilities need upgrading in Fiji. There needs to be more focus on prevention rather than cure. Health sector needs to be more proactive. For example, HbA1c versus random blood sugar. And HbA1c is the only test that can assess pre-diabetes in the community. Community education, traditional knowledge versus Western knowledge. They must learn to value that their traditional knowledge still carries a lot of weight. More research needs to be done to understand the risk of type 2 diabetes, maybe with laboratory testings as well.
Thank you, Esala, both for your work and for sharing your own experience. It's really critical for us to hear this lived experience of climate change and the research. It's a reminder that climate change isn't a future threat. It's really impacting people's lives right here, right now. I think the other thing that your work has done is highlighted the ongoing impacts of colonisation and how that drives many of the intersections between social justice and climate change. So now I want to hand over to our final speaker, Aimee. Aimee is Director of Integrated Wellbeing at Healthy North Coast, a public health network in New South Wales, Australia. Aimee has led the delivery of over $40 million in disaster programs since the 2022 Northern Rivers floods, providing critical health system support across prevention, preparedness, response, and recovery. This work recently won the Resilient Australia Mental Health and Wellbeing Award for New South Wales. Aimee also leads procurement and commissioning activities to establish mental health and suicide prevention services across the North Coast, including the establishment of safe haven sites which deliver clinical and non-clinical support to flood-impacted communities. Thank you, Aimee. I'll hand to you now.
Thanks, Karyn. Firstly, I acknowledge the traditional custodians of the lands we meet on and elders past, present and emerging. And I'd also in particular like to acknowledge the First Peoples of the lands I'm about to talk about today, which spans the 3 nations of Bundjalung, Arakwal and Yagal Nation. All right, so I'll start with a bit about Healthy North Coast. So we are approximately 520,000 people live on the North Coast region, spread across the region in diverse locations. So we have a range of centres, very remote and regional, and more metro sort of style communities as well. So our major population centres are located on the coast and major river systems that divide the region, with more rural and remote townships located inland. The North Coast region is more disadvantaged when compared with New South Wales. Disadvantage indicators include high ageing, Aboriginal, disability, remote and unemployed populations. We deliver programs as a commissioning body, one of which is the North Coast Primary Health Network on behalf of the Commonwealth Department of Health and Ageing. As a commissioning organisation, Healthy North Coast prioritises initiatives that strengthen the health system resilience for effective future strategy, with escalating frequency and severity of climate disasters projected. There are important learnings to be shared through this. So the scale of the flood in 2022 is a cautionary tale for every region in Australia and further beyond in the context of changing climate. Think of the worst case scenario disaster your region could experience and then double it when you consider what's occurred in the Northern Rivers region. So as you can see on the page, I have included our strategic plan for the next few years to 2030. And as you can see, key to our work is sustainability and thinking about how we can proactively support resilience in our health system and prepare for communities to be climate ready, because it is something that is going to continue to impact on our region. So a bit of an overview of what I'll be covering today. So the 2022 Northern Rivers flood showed that place-based primary healthcare innovation strengthens the health response in disasters. Community health system resilience reduces the impact of disasters, as well as reliance on acute and out-of-region resources, which is what primary health networks aim to support in day-to-day business anyway. And primary health networks and primary health care offer unique value and need to be embedded in national and state disaster management frameworks and responses as well. So what happened in 2022? Leading into 2022, many catchments in New South Wales were full and soils were saturated. This was due to La Nina event in March 2021 that led to widespread flooding. The Bureau of Meteorology declared a second La Nina event for Australia in September. Commencing in November, New South Wales SES responded to 109 consecutive days of flooding in large parts of Western New South Wales, resulting from rain in northwest New South Wales and inland Queensland. From 22 February, a low pressure system across northern New South Wales and southern Queensland produced heavy to torrential rainfall over the New South Wales coastline. This followed by 2 more weeks of persistent coastal rainfall, including the development of 2 east coast lows, led to flash and riverine flooding in numerous locations. Multiple communities in the Northern Rivers area experienced unprecedented flooding, with records broken by considerable margins. Devastating floods occurred in Lismore, which experienced two floods in the space of a few weeks. The levee at Lismore overtopped both times, inundating the town on each occasion, and townships of Woodburn were also inundated. Other towns experienced significant flooding were Corrokai, Murwillumbah, Tubbulgum, Broadwater, Ballina, Kyogle, Byron, Ballingen, Clarence Valley. So we have 12 local government areas, and as you can hear, a significant amount of those were impacted by the flood events. The National Emergency Management Agency describes the 2022 Northern Rivers floods as one of the most devastating in the nation's history. Since the Northern Rivers floods in February 2022, as Karyn mentioned, Healthy North Coast delivered over $40 million in disaster management programs. I didn't deliver them specifically or myself, but our organisation led the implementation in that space, which was in the primary care and community sector to support a joined-up health system response to disaster in our region. Collaborations with a wide range of stakeholders implemented over 23 initiatives to support health system support across prevention, preparedness, response and recovery. And we have tangible learnings from the delivery of primary healthcare in emergency situations, ensuring continuity of care for impacted populations. Highlighting the critical role of primary care coordination during disasters, Healthy North Coast's response demonstrated the effectiveness of an integrated approach. Key outcomes included credentialing, coordinating and rostering clinicians to evacuation centres. So clinicians included general practitioners, nurse practitioners and psychologists and counsellors to support mental health and wellbeing. We developed guidelines for general practitioners working in evacuation centres, strengthened local relationships within the healthcare sector and identified the need for improving disaster preparedness among primary care providers. So the unprecedented displacement affected more than 10,000 residents evacuated into 32 evacuation centres, 6 of which were community initiated because they couldn't access any of the 32 centres. The event affected over 40,000 people across more than 50 towns and villages. And as a local primary health network, we had to act quickly and flexibly to meet the urgent emerging needs of our communities. So our activities included daily liaison with our Northern New South Wales local health district and response agencies. We leveraged our existing relationships to mobilise resources, information and support. Local knowledge, data and innovation capabilities to tailor solutions that fit the context and circumstances of each community, which is very challenging with so many communities impacted. And it's estimated that 4,000 homes were made uninhabitable and 10,500 damaged. Housing loss in an area of this existing shortage is a pretty significant impact on social and determinant wellbeing outcomes. So as I did reference before, over $40 million of funding was provided to Healthy North Coast through Australian and New South Wales governments. Thank you to both parties. Disaster recovery programs and initiatives have been in place since March 2022. Some of these include GP telehealth promotion. So we were able to share GP access via telehealth to support prescriptions, consultations and medical certificates for community that couldn't access because general practitioners were closed down due to inundation or other event or not being able to access the sites. The We Are Open initiative funded extended hours for practices and pharmacies so people could still access support outside of the usual hours. Temporary health service provision in evacuation centres and isolated communities, so coordinating clinical volunteers. And later we worked with RACGP to support that. Street-side medic vans, of which 1,500 occasions of services were delivered with medics touring around to communities that they could access to provide in-reach support. Coordinating information about open and closed services or changed hours, and then the primary care healthcare precinct. So we were able to work with Southern Cross University to lease some of the premises and make sure we could support around 30 displaced primary healthcare clinicians to continue to practice. We also supported residential aged care facilities. As mentioned before, we established 4 safe haven services in record time. Within a couple of months of the flood event, we had 4 services available, providing clinical and non-clinical mental health and wellbeing support to people in the community via a walk-in, no referral needed support program. We also supported the establishment of a pop-up adult mental health centre in Lismore, which has since become a full centre, providing much needed mental health support to the community. In the recovery space, a lot of work was provided around a local buddy locum model, team debriefing and wellbeing, training and supporting patients that were experiencing post-traumatic stress disorder symptoms and diagnosis. And also other workforce wellbeing programs with grants offered to primary care providers to deliver whatever they needed in practice to support their wellbeing across the teams. I already mentioned the centralised mental health intake line. We now transitioned that into a head to health centre. So anyone that was flood impacted was eligible for commissioned mental health support, and the usual eligibility criteria was removed to ensure that people could get access to the support they needed in a timely way without having to go through the steps such as seeing a general practitioner to access mental health treatment plans. 23 mental health providers across 10 evacuation and recovery centres were co-located to ensure that support was accessible for people in the community. We set up 10 health and wellbeing flood recovery navigators, and these provided a really vital role for pod villages and temporary accommodation sites to help support coordinators and RSS recovery support teams to be able to step people through the complex health system and make sure they got the right support they needed to manage their wellbeing. And Resilient Kids is another really key program. It's Australian first for young people impacted by extreme weather events to recover and strengthen their mental health and resilience. So that was born from a really big and robust evaluation of children and young people across the region, with around 7,000 respondents, providing us with insights around the sorts of supports and services they might need in the community to be well and remain connected. Primary care in health infrastructure was really adversely impacted. As you can see, a couple of the photos in no way encompass the breadth of the impact across the region, but general practices and community pharmacies and other primary healthcare services are not considered essential services, so they're slower to get power back on and not prioritised for assistance initially. So non-cloud-based systems meant clinical data was lost and really significant impact was experienced across the practices. Some practices missed out on medium business grants due to contractor workforce. So then the federal and New South Wales government supported a flood infrastructure grant program, with 21 practices receiving infrastructure grants to get back on track and be able to provide the much needed support and services to the community. So we have learnt a lot from our approaches in the last 2 years, and the National Disaster Risk Reduction Framework and Victorian Bushfire Royal Commission shows that the most resilient communities are those that are most connected, and they do tend to bounce back quicker and are less traumatised. So resilience is built alongside communities, not for them. So we did implement a community wellbeing and resilience program that funded grants-based, place-based initiatives that supported disaster recovery and build communities' ability to face future challenges. So $5 million was invested into 23 local initiatives across 4 years. And we've currently kind of evolved that approach, and we're looking at a participatory grant making approach now, of which we've just awarded 3 new grant recipients, which aim to strengthen partnerships and community and connectedness, encourage that collaboration and resource sharing and innovation, increases the diversity of the grants that are provided on the ground, and that practical place-based solution will address the community needs this way. And as mentioned in the introduction, we were awarded in the New South Wales Disaster Management Awards for the approach via the participatory grant making. So 2.5 years on, our communities are still in recovery. We've still got about 2,000 people that are living in temporary and emergency accommodation sites. So the development of Healthy North Coast Disaster Management Framework has been helpful for planning for us, and we've got to consider how we both respond to the current needs from the response to this 2022 flood event, and also what can we do to make sure that we can support future planning and responses in this space as well. So our next steps are a whole of health disaster management planning program and suite with our 2 local health district partners, scenario planning with all response agencies, ongoing discussions with federal and state government, development of new approaches to support primary health care and resilient communities in disasters. We've led a number of reviews and input into a range of different strategies and inquiries, including the Reconstruction Authority Act and the National Health and Climate Strategy, so that we can make sure that our learnings contributing to policy and planning in the disaster management and preparedness space. I have included our website here for further information about our work. Thank you very much.
Wonderful. Thank you, Aimee. Wow. Also, really highlighting the critical role of healthcare services in community disaster resilience, including that long tail of recovery and how it's all important part of climate resilience, and also the complexity and the amount of work involved. So, thank you to everyone for your great presentations. Truly, I think there's much for us to really listen to, learn from, and support. Before we get started on the Q&A with our presenters, we're going to be sharing a Mentimeter link in the chat and a QR code on the screen. So CAHA is encouraging everyone to think about your key takeaway that you'd like to share from this session, and you'll be able to see everyone's responses live in Mentimeter. So let's turn to our first question, and in the Q&A, I can see our first question has come from Michelle, and I think this one is for Esala, and the question is about environmental combined with social determinants of health has created poor health. Has there been an assessment of the intersection between well-being, stress, and ancestral belief, or the assessment of I think, Michelle, correct me if I'm wrong, the impact of climate change on well-being and ancestral beliefs? Is that so? Esala, is that one you might be able to speak to?
Can you hear me?
Yes, thank you.
Yes, I didn't come across any assessment of climate change upon ancestral beliefs. But growing up in the islands, we've always lived in a collective environment, and that in itself is a resilient, one of the factors of resilience, and a benefit of living in the villages. So I guess, yes, in a collective environment, villages, it becomes a natural mitigation to climate change and climate crisis.
Yeah, indeed. Thank you. Our second question is also for you, Esala. And the question is, do you know how the healthcare systems are coping with the increase in diabetes? And is the government playing a supportive role in addressing that?
Yes, before I came here, I've been in New Zealand for 6 years. I used to work as a surgical registrar in Fiji. I also did my Master's of Medicine in General Surgery in Fiji. And amputation rate is 1 in every 7.5 hours. That was before COVID-19. So now post-COVID-19, it's probably worse than that. And type 2 diabetes is the most significant health problem impacting Fiji. There is a need for preventive care more than curative. I worked in general surgery, a tertiary institution, but what we're sorting is something at the tail end. We're sorting the tail end of the problem. Things like HbA1c or glycated hemoglobin. This is a way that we can prevent type 2 diabetes, and knowing that type 2 diabetes is preventable but not curable. But if we continue with what we're doing now, especially in rural and remote areas, random blood sugars, that is not preventive. That is just identifying or diagnosing those that are already living with the disease. So there is a need to push towards that. Thank you.
And is the government supporting that kind of preventative work, or?
Yes, at the moment, the government can only support what they can afford. When there is reagent, we can do HbA1c. But when there is no reagent, those that can afford pay $30 per blood test. And knowing that HbA1c goes with a red blood cell life cycle, which is about 120 days. And then there needs to be repeated. So $30 for every 120 days. And especially those that need it the most in the villages, they cannot afford that.
Okay, another social justice issue for us. I will encourage our audience to please put your questions in the Q&A. And before I get into my own questions, I have seen one in the discussion forum, so I will break the rules and read that one out. I think it's to the entire panel, and it's from Kylie. It says, crisis brings out the best in people and supports people to mobilise and respond. How can we take that approach back into business as usual? Does anyone want to take that on? Maybe into our planning, perhaps. Is anyone on the panel have thought?
I can take a stab. at it. It is right that crisis brings out the best in people. We saw that a lot through Cyclone Gabriel with a lot of community community responses, people still working collectively. In fact, so Cyclone Gabriel, for those of you that aren't aware, was in February of 2023. There are still communities that are connecting because, as you said, all of these events have an incredibly long tail. And just because this happened in February 2023 doesn't mean that the issues that it's raised have been resolved. And so the community in Esk Valley, which is one of the impacted areas, is still meeting regularly now to support each other through many of these issues. And I think, the real learning for us, and this is something that we are really, which we've done community as in the professional community well in New Zealand, and particularly with the scenarios work that I spoke to. But actually what we're really trying to work on is how we can be using all forms of knowledge to inform the processes and the way that we approach this moving forward. And so that could be Indigenous knowledge, it can be community knowledge, it can be scientific knowledge, it can be political or sectoral, or so I think that really that's the approach we can be bringing back into BAU, is ensuring we're using all forms of knowledge in creating our plans and strategies, and community knowledge is certainly one of those.
Thank you, Vicktoria. We have another question, and I might throw this one to Aimee. Cat B says, I'm loving the consistent theme of community collaboration. What advice or approach would you take across our healthcare systems to try and embed that community collaboration?
I think it's what's in it for me, the old adage of trying to find what we're all, like that common ground of what we're all trying to respond to. And I think when you're experiencing such significant adverse events, the similarities or common themes across the health services and community are very apparent. Limited resources, limited funding or money or financial capability to respond at the breadth that is needed. So it kind of shifts people into a focus with leveraging what resources you have to be able to move through the work. I think what's really key is not just relational structure and system. It's more about focusing when you're not in a disaster or a crisis on putting in place the systems that can, like memorandums of understandings between local health districts and primary care services, service planning and health planning collaboratively. Because you can then draw on that when you are responding to events or thinking about what's needed to prepare or mitigate for future events as well. So it's not just relationships then that you're relying on, it's that consistent plan and approach that you can reference to guide people to move through the same work with the same vision and goals to, improve outcomes for the community. I think that's where we've moved, so that we're able to kind of stick to what we need to do and collectively achieve. I think the wins are really helpful too, like taking some time to celebrate what you have achieved or where the community has been able to build something and respond to a need, sharing those learnings across the health sector or also with the health sector. Makes it more collegiate and also helps you to then think about what else you can bite off together to achieve something. So I think there are a few areas there that you can use to get some momentum.
Yeah. And I'm wondering maybe Kate and Carolyn, you might have some reflections on that question as well.
Yeah, thanks, Karyn. I take an approach that's very much centred in prevention. So prevention across the board, is underfunded in our country. And when you are funding prevention properly, you're addressing, the issue of community health, social justice. We're embedding our communities with more resilience because they're stronger, they're healthier, they're preventing chronic disease, they're more socially connected. So I start upstream, and I hope that, in the future we might see a waking up to that knowledge of let's prevent chronic disease so we're not putting so much pressure on the healthcare system to make us well, and that the communities then are sort of empowered because they're taking more control of their own health and well-being from the beginning. So the other side, I guess I could answer from is consumer voices. So community and consumer voices within, collaborative partnerships in healthcare settings is very useful. So you've got people with lived experience out in the community that these healthcare services are based, understanding, and representing the issues of their community.
Well, thank you. And I'll reveal my biases. I would encourage you all to have a look at the Wellbeing Economy Alliance. I think that really talks to some of these issues too. Vicktoria, I'm going to come back to you because I think scenario planning is so critical for adaptation and the kind of scenario planning you were talking about. Which was the more challenging scenario to develop and why?
Yeah, I mean, that's a really good question. I think the most challenging scenario to develop really was the 1.5 or the orderly or ambitious scenario. And the reason for that is that so that's mandated. We have to do a 1.5 pathway as mandated in the reporting standards, but actually it's almost a dream world view. And I'm being a bit bleak, but sorry, I work in climate risk and adaptation, and so I can't help it. It just goes with the territory. We saw around 50% of days over 1.5 degrees last year globally. So actually creating this wonderful dream world view where there's as many risks communities is almost like, what's the point? In saying that, though, it does provide some hope, and hope is really important in this discussion, and also from a health perspective, which is obviously the environment in which we work. It's really clearly showing the health and well-being benefits from a real, incredibly determined and dedicated action on climate. So there was some benefit in there. I do recommend, and the links are there, just search healthcare sector scenarios New Zealand and you should find a link to them. They're definitely worth reading. There will be some things that are relevant also to those of you in Australia. But I think if you read the hothouse scenario and you don't think, oh dear, and that's not the word I would use, but that's an appropriate word for this forum, then you haven't read it properly and you need to go back and read it again. And actually that's the trajectory that we're on at the moment. And as I said, it's not a prediction, but many of these things so this was published in May. Basically the content was finished around early in the year. And some of these things we're already seeing play out, and I'm like, it's not a guideline. We're not supposed to try to meet the things that are written in here. So yeah, I can talk about this for hours, so I will stop myself now, but do reach out to me if you want to discuss this in any more detail.
Yeah. And I give credit to New Zealand. I think they're really engaging with the adaptation pathways, methods and ideas in the work, I think. Yeah. So kudos. We don't have any more questions in the chat, but I have one more question, and that's for Elise. I'm listening to the presentation, and given the significant implications of climate change impacts, why do you think adaptation was rather less considered?
Oh, I hope you're not ending on me, because I would love to keep talking and hearing from insights from all of the panelists. It's a really interesting question. I think, it's partly, as I said, a reflection of the countries that we identified for our review. And I think in Australia and in high income countries, there has rightly been a strong emphasis on mitigation efforts in what's been published. We know that nearly 80% of emissions worldwide are from G20 countries, including Australia. And in a country like Australia, the healthcare emissions are a substantial segment of overall emissions. But I think it also reflects what is kind of within the sphere of influence and control of some of the leaders within these healthcare facilities who are able to design, implement, and then document and publish evidence of these approaches. In lower resource settings, there was the studies that we identified, there was a lot more focus on adaptation. And I think that, again, partly reflects the different contexts. We know that in many of these countries, the impacts, in Australia as well, but, perhaps we are a little bit more sheltered given our socioeconomic status and resources, but the health impacts and infrastructure impacts of climate disasters are increasing, they're extreme, and they're compounding. So they've had to focus on and prioritise adaptation. And, many of them are also looking at implementing mitigation alongside that, recognising the impacts in areas where they have, an opportunity to reduce healthcare emissions. But I think in higher income countries, we really do need to shift to both look at integrated approaches, of which there have been several really amazing examples today, because we know in our country, and particularly for vulnerable communities in rural areas and vulnerable communities within urban areas, that these impacts are increasingly being felt.
Without question, we have to do all of it all at once and quickly, I suppose, is the short version. I'm going to indulge myself once more. Just thinking about all the work that you all do, how do you take care of yourselves and the people that you work with? Because when we work in these fields, we often forget to do that. So I'll leave it open to the panel, but really, how do you do that?
First. So two things. I go to quiz night, and I can't believe I've reached that point in my life where quiz night is like one of my highlights of the week. And apparently I know about more stuff than just climate. So that's nice to be reminded as well that there are other things that exist in the world and it's not all about climate change. And the other thing I do is I paint dot mandalas, and it's just one of those things, like you get your creative out. So yeah, creative and friends, I guess, is what I do. I should say things like getting into nature and blah blah blah, but I'm being honest. Kia ora.
We do that too. Thank you. Anyone else? Oh, I'm getting the 2 minute.
I quite like to bake. Quite an avid baker. I live on 130 acres in an off-grid property, and so I get to enjoy that without worrying about the impact on our environment at the same time, which is lovely.
Thank you.
Okay. I love running, and I obviously, being in the Loddon Mallee, live in the country, so I go on long runs on country roads. And I also very much limit my exposure to news media. And I very much enjoy cuddling all the members of my family when I'm feeling a bit down. But certainly Psychology for a Safe Climate is the work they do, I really, really appreciate. And I do find them to be an excellent resource.
I have two very needy dogs, so they force me to keep active as well as getting in nature, which are massive solves for me. But I also am fortunate to be able to work and connect with many amazing colleagues in the climate and broader health spaces, and fortunate also to get to work with some communities in our region. So I find coming to forums like this, and I actually find a lot of the work and the perspectives that we're able to hear from very energizing for me.
Thank you. Esala.
To run as well when I'm stressed, it opens up my mind, clears my mind as well. And given that my topic is on type 2 diabetes, I guess I have to walk the talk.
Thank you. I pushed the limits of our timing. So thank you to all the presenters for generously sharing your stories and experience. That does bring us to the end. As mentioned in previous sessions, please use event stream, post an update, image or response. We'd love to see you set up. Don't forget the Meeting Hub provides an opportunity to connect with other attendees. Please stay on and mingle with other attendees. At 2 p.m. Australian time, the Bupa team will be available to chat. And next up in the program, our final session is tomorrow. So we'll hear stories of progress from preview presenters at past forums. Wow, that's alliteration. Following this will be the forum closing, which will include announcement of this year's Healthcare Climate Challenge Award winner for the Pacific region and a reflection on the past 2 weeks. We hope to see you there. Thank you all. Stay safe, travel well. Goodbye.